So, welcome everybody to now the 12th week of the Business of Healthcare show, HCBiz. We got a couple of docs that are here. They're going to talk about the front lines of MACRA and what they think about it and what we're doing about it. I do want to get into a little bit of that, opinion and reaction a bit. But what I'd like to focus in on, in traditional HCBiz sense, is what should you be doing right now? What outside of the comment period and given that feedback to CMS, assuming the rule ends up looking something like it does as proposed today, something pretty similar, I would assume, what should doctors be doing and how can they best position themselves to get to be ready for 2017 and beyond? And even further than that, what opportunities might it create for people who, once we get past the original fog of the complication of the rule and the reaction, like where are those opportunities hidden inside of the rule and what can we do about those? So that's my hope. If you want to each give the audience a 30-second intro, who are you, where are you from, and what do you do? Dr. Mike, we'll start with you.
Okay. You want a little introduction first?
Sure.
Yeah, I'm Mike Koriwchak, and I'm an ear, nose, and throat doc in Atlanta that's been blogging about health IT for about 6 years and been doing radio shows about it for about 2 years and have been, networking and going to Washington and visiting with folks and, trying to be as much of an activist as possible regarding health IT policy as it affects physicians. I'm the vice president of a 501c3 called the Docs for Patient Care Foundation. And the health IT part is my bailiwick, but we have some other issues that we work with as well.
Excellent. Thank you. And Randall, same thing, just a quick overview for the audience. Oh, he looks frozen.
He looks frozen. He looks like he's not fully connected at the
You are not with us right now, Dr. Oates. All right, so we'll wait for you to work that out.
I can go on and give you my response.
Yes, please do.
Your question about what should we be doing right now. I think the most important thing that people need to be doing is reviewing the proposed rule and responding to it. Anybody who cares about this needs to write CMS and needs to put their comments in, because the more they hear, the better the job they can do. I've got some serious issues with this legislation that we can go into if you so desire. It is my intent and my hope that this does change significantly between now and a final rule. So in terms of, how to tool your practice up at the moment, I wouldn't recommend doing anything in the hopes that some of the more onerous parts of this thing from both a philosophical standpoint and from a working standpoint will change favorably. So in terms of what to do, I'm not really sure what I would go to my administrator and say, okay, this is coming 1st of 17. What do you do? I'm hoping that, we can hunker down and put all of our bandwidth into responding to this thing in the most complete and sophisticated way as possible. And then hoping we get some favorable changes that make a lot of that upfront work unnecessary.
Got it. Okay. Well, yeah, let's start there then, because if your opinion is that you should hold waiting for the comment period to play, then, let's get into that a little bit. First, I guess I'd like to know what some of the issues are that you have and that you're going to be commenting on. And then secondly, how can the providers work together? How can you guys kind of coordinate your comments and make sure that the voice is heard, especially if you're coming from the smaller practices?
Well, the CMS, to their credit, has certainly, at least given lip service and partial, at least, actual practice of wanting to hear input. And so far, and you and I have talked about this, in my personal experience with Andy Slavin and his team, so far so good as far as conversation goes. And before the rule came out, we did some work with their mission statement and their vision statement and even the name of the program, Advancing Care Information. And they were listening to others, besides us, of course. But they did listen and say, look, you need to avoid words like payment and incentive and quality, because physicians in general react negatively to those. So it's been a good job so far, but so far it's only been the window dressing. The real work begins now that the rule has been issued. And, I'm in a group that sort of divvied this thing up. And of course, I took the part on IT and meaningful use. So this Advancing Care Information Program, right? This is this new name, it has got some issues. I'm getting a lot of echo. Are you getting that too?
Yeah, a little bit. That might be coming from Dr. Oates.
I can try to. Oh, that's better.
There you go.
Okay.
Perfect.
All right. So let's talk about advancing care information, the problems that I have with it. I've gotten the commitment both, personally face to face from the CMS crew and elsewhere that they're going to reduce the burden to physicians in terms of reporting. And there is some meat to that, and they have done some things. I don't think they've gone nearly far enough. I think that the requirements for advancing care information are far too complex, far too confusing still. They have given some lip service to it. They've gone from having to report 9 measures down to reporting only 6 measures, and that's a move in the right direction. But even if you go back to comments that Don Berwick made back in December of 2015, he said, look, we've got way too much data being reported. And he said we need to reduce these numerators and denominators and these quality measures by at least 50%. And, this was part of sort of a 9-step proposal that he put out last December. And 9 to 6 is not 50%, it's 30%. So, we need to go from 9 to 4 at least. And then that is something that will be impressive. And then we need to get rid of, there's 3 sets of criteria for getting through advancing care information. And so it depends on what level you're certified. There needs to be some sort of, cleaning up of that and make it one set of criteria, make it clean. And then we've got to look at all of these quality measures in the first place. I'd like to know what has CMS done with the data we've already reported in the last 6 years, right? I mean, terabytes and terabytes of data presumably sit in their servers. What are they doing with it? I mean, is there any proof that all this data reporting is actually doing any good besides just documenting our compliance? Anyhow, I've talked long enough.
No, it's a great question, and it's a good point to pause and kind of pull you back in, Dr. Oates. The context for the conversation was, I don't know how much you heard of it before you froze out before, I was looking to, certainly get into reaction and opinion a little bit, but I really wanted to talk about what should doctors be doing right now. And Dr. Koriwchak's response to that was basically, don't do anything in your practice right now. Understand the rule, respond to the rule. Don't just accept it for what it is right now, but effectively try to work together to get that feedback up to CMS. And it's, you sound hopeful that they're going to review that and consider it, and you hope that there could be big changes. So having read some of your work, Dr. Oates, I know that you're going to have similar thoughts. So that's the setup, and we'd like to hear from you on
it. Can you hear me?
Yes, very good.
Okay. I have to agree with the statement that it's too early to be making plans. It's time to be getting up to speed with the proposed rule and plan to make comments. And, I want to see it succeed. And I have some very significant concerns building on what Dr. Berwick published on the inherent likelihood of failure of using outcome-based metrics as a system of rewards and punishments. It's just inherently designed to fail by every example I can find in the literature, taking, for example, the Leave No Child Behind initiative, where there was this plan that through centrally defined metrics and checking outcomes, there would be rewards and punishments. It miserably failed, and by all indications, it looks like we're headed down the same path. In fact, the experience would confirm this, and I point to the UK, where in 2004 they launched with great fanfare and public funding the QOF, the Quality Outcome Foundation, where the intent was to establish these set of quality measures, quality.
Yeah, in quotes.
In quotes. And, they're basically annualized performance metrics. And I've put a link into the live chat to a discussion by one of the thought leaders in the UK that are trying to discuss what do we come up with now that we know that these annualized performance metrics have been shown to fail. What do we replace them with? And I wish as a nation we could avoid making the same mistakes that the last decade has shown doesn't work with the centrally mandated annualized performance metrics as a tool to reward or punish. It just doesn't work. When you with these, what you create is a gaming system where at the point of care, the health professionals are doing what they need to do to meet the metrics or pass the test and not do what leads to the best outcomes for their unique and individualized patients. And I just hope that if there's any chance for an iterative correction, we need to be focused more on systems-based patient well-being, and how do we reward the things that patients value, not some algorithm that or metric that really patients don't value.
Right.
And
yeah,
I think that's our real challenge. But for me, a little background, I practiced family medicine for almost 30 years in Northwest Arkansas. And now I'm the president and CEO of Soapware My Healthware, an EMR and patient engagement platform. And my challenge with this is how do we actually deliver value to patients in spite of a value-based metric system that actually interferes with the delivery of value-based care. And we've got to help our community of users to navigate this, give them tools to play the game, to pass the test, but still, hopefully, we can improve patient outcomes and deliver value in the process.
Yeah, and I thought that was a great quote from your paper that you sent me last night about, if quality measures, if you're right, if quality measures are doomed to fail in that regard, then your task right now is to basically be really good at failure while also taking care of your patients. And
right.
It was an interesting way to put it. It caught my attention. And this whole thing now has been a big theme for us for really over the last 12 weeks of HCBiz. Is whenever you have heavy intermediation, as we do in healthcare, it takes out that kind of natural voting process of the provider spending their money, the patient spending their money. And you take then, we would have 3.5 trillion votes, if you will, about what's best for patients if they were paying, but they're not. So we have a couple thousand votes of the payers in Medicare and Medicaid. And that's what necessitates these types of programs and quality measures and, trying to incent the behavior that we hope to get. So I think that the right now we could probably all agree that the quality measures aren't going away. Even if there was a way to do it and we could all agree that it was best, it's not going to happen, certainly not anytime soon. So where is that compromise between, lots of quality measures? Dr. Mike, you referenced the 50% reduction. We've got down about 30%. What's the compromise? What can we do? What can we measure that doctors would look at and say, yeah, that's meaningful. That's worth looking at. That is an actual indicator of value in the work that I do, versus which ones do you think don't provide any value and should just go away?
Well, my plan is going to be to challenge CMS to say that any quality measure that's on their list, and there are some 465 of them in the appendix at the end of the rule, needs to satisfy at least two requirements. The first is that they need to have a plan as to what they're going to do with the data, right? If I have to report on, chronic external otitis or acute external otitis, which is one of the ENT quality measures, or one of the general surgery quality measures is that I've had a conversation with the patient discussing their, perioperative risk, then what are they going to do with that data? Do they have a plan to, let's use scientific method here for once and develop a hypothesis, develop a measuring method, then get your data, then measure your results against the data, as opposed to what they're doing, which is just arbitrarily create the measurement method first and then hope that some sort of miracle falls out of the data. It makes no sense. So I think one of the ways maybe to get around what you're saying, which is absolutely true, which is the measures ain't going away, there's too many stakeholders that want those, is to challenge the folks who support these and say, okay, what are you going to do with this data besides prove that we're compliant with something arbitrary, artificial, and I would contend largely useless? So criteria number one, it has to be something that you're actually going to use the data to do some good and use scientific method, hypothesis first, measurement method second, data third, evaluation against your hypothesis fourth. And then the second criteria, totally unrelated, still important, which is that anything you create has to run in the background. And this circles back to challenging the vendors, right? If you want to gather data on how I'm evaluating my patient preoperatively, let's say, which is in the general surgery criteria, then you need to design a method that lets this operate in the background so I can do my job the way I'm supposed to do it. You want to gather the data, fine. But I don't want more boxes to check. I don't want more hoops to jump through. And I don't want to spend hours and hours with my staff coming up with an entirely new infrastructure just to report data that nobody's going to read.
Yeah, right on. I could buy into both of those requirements. In fact, my training as a software developer, the first thing I was taught was IPO. Inputs, processes, and outputs. And my boss that was training me drew 3 columns on the board, and I was never allowed to write in any of them except for the output column. And it was it was frustrating at first, but eventually I realized it is that you should have no process and you should have no inputs until you know what your outputs are, and then you should have no inputs that don't drive an output. And it's a good way to get down to
excellent way of saying the same thing. Yes.
Yep, right on. So how about same question, Dr. Oates? Anything to add to that? What's good about what they're trying to do, or what can be good, what measures can be good, and what stuff needs to just go away?
Well, the more that the metrics can actually measure what is value to patients, and that is, can they get access? Are there health professionals available? Are they coordinating their care? Are they knowledgeable? Are they competent? Those are the kinds of things. The work that Barbara Starfield did 10 years ago is a good outline of the things that are truly of value. And in contrast, I would say that if you're using outcomes-based performance metrics, and I agree they're not going away, but the evidence is overwhelming. Whether you look at teachers in the U.S. or you look at physicians anywhere in the world where these systems have been implemented, it destroys the altruism and the creativity, the innovation. It demoralizes because of the whole nature of it. I'm saying it's a fallacy, and I would argue that what patients really value the most is, do you care? How humane are you? How well can you connect with them? What's their level of trust in you? And that's a very difficult thing to assess. Don't get me wrong. I think performance-based quality metrics are an excellent tool to use for quality improvement. And that's where they should be used. So you can see what are your processes that need the improvement and engage those. But to across a whole population, try to say that you should do a fall risk assessment on everyone over 65. Well, heck, I was in a practice a couple of weeks ago where there was a 75-year-old man that was competing in Ironman competitions, and the medical assistant was doing a fall risk assessment on this person. I mean,
Exactly.
This was not, I mean, this gentleman was perplexed and said, why are you wasting my time on this? This is not what I wanted to come in and spend my limited time discussing. And, you know, I could go down the list, but, you know, we really need to be focused on what is of value to the patient.
Perfect. Thank you so much.
Yep.
And how do we measure that?
You got.
I know they're trying with the CAP scores. I assume that's one of the goals. They're trying to understand what's happening there, and how the patients are perceiving the care they're receiving.
I think CAP scores are great for a quality improvement, but not as a foundation for rewards and punishments. Simply because, I mean, there's overwhelming evidence that the higher the patient satisfaction score, the lower the quality of care and the higher the cost. And you look at what the patient satisfaction surveys have done to antibiotic and narcotic prescribing. I mean,
Oh yeah.
It's almost criminal. Yet physicians are getting blamed if they have a low patient satisfaction score, but anybody that's been in the trenches knows that that person coming in expecting that unnecessary antibiotic are wanting to take narcotics that really aren't in their best interest. If they don't walk out with it, your patient satisfaction scores are going to put you lower than you want to be, and you may risk getting your full salary or bonus that's being based on that. You shouldn't link the financial reward or punishment on the results of that kind of data.
I mean, think about that. You said it so well, Randall. That's so perfect. That's everything you said in the last 5 minutes is a notable quote. And even John Lynn said so down here. MACRA kills the altruism in healthcare. Beautiful thing. It's so right. And it's interesting that you brought up teachers and No Child Left Behind, because here in Atlanta, we had a huge scandal in the public schools over No Child Left Behind, where all the way up the chain of command, people were taking the student standardized tests and changing they were erasing the number 2 lead pencil dots and fixing the tests so that the scores were better. And there was a huge scandal and a lot of convictions and a lot of resignations. But it's the same thing. You're putting people in a huge ethical dilemma, where you have the choice of doing the right thing and being badly harmed, or doing the wrong thing to survive. And,
Exactly.
Nobody's immune to that. That's awful.
Yes. We create a system where we're playing the game rather than looking for the best outcomes when you
Absolutely.
use these performance-based metrics.
I mean, think about the VA. I mean, it's another great example of, quality metrics, right? Everybody checks the boxes and gets their bonus, and veterans die.
Right.
Yeah. So now this, just to back up a little bit, is not new to MACRA, correct? I just want to ask that question. Do you see any of these issues that you're dealing with, do any of them not already exist today? And this is, MACRA is just the next iteration of them, or is MACRA introducing anything that you think deepens these issues?
Well, what MACRA does is it brings the entire thing into sharp focus, right? In other words, part of what CMS and the rest of the bureaucracy has enjoyed to this point is, PQRS lived in this little corner, and meaningful use lived in this little corner, and HIPAA lived in this little corner. And so you'd pay attention to one at a time without looking at all 4 corners, without looking at the whole. Now, MACRA allows everybody to look at the entirety of this, and the folly of the whole thing comes into sharp focus. So MACRA is raising issues that are years old. It just rubs it in your face, and oh my God, it's just horrid.
Gotcha. So in maybe a bit of a sadistic way, that's a good thing, I'd argue, that we are all looking at the same thing now, because I agree, you may have been a meaningful use expert before and not known anything about what was going on PQRS. So I think getting all eyeballs in one place, that's a really good point. I think that's an important, I'll call it a win of bringing it all together. So my next question would be, how would we measure, absent just free market, letting all the dollars be the votes for themselves? How do we measure what's important to patients?
Well, that's the nut to crack, isn't it? When you talk about MACRA raising bigger issues beyond MACRA itself, that may be the single biggest one, which is, how do you measure quality? How do you measure value? Value is generally defined at the point of a two-party transaction, right? If you're selling something and I'm buying something, and we agree on a price, that's your value. And when that happens millions of times in an open market economy, then the aggregate data determines value. When you introduce a third party, you corrupt that two-party concept. And when you try to measure value after the fact, with all of this quality, again, just like Dr. Oates said, in quotes, quality reporting, then the process is inherently flawed. And we keep patching, and the whole thing is put together with duct tape and baling wire, and the more complicated you make it, the fancier the plumbing, the easier it is to stop up the drain. And that's what you end up with.
Got it. And that's definitely regulation on top of regulation for years. You see it when you get into the back office of the practice with the tools that are strung together, and there's in the larger groups where there's then been some turnover too with that administrative staff, it's often nobody in there even knows how all of the stuff works. And there's a lot of, I'm hands off. You don't touch that piece. It works. It's doing its thing. Just hands off. We'll try to add something over here. It gets pretty complicated.
Yeah.
So,
and John is commenting too. This is important too, which is to align incentives. And he made a comment about that, which is not just how you measure, but how do you get patient, doctor, and payer all wanting the same thing? Yeah, right. Because right now, docs and patients want the same thing. All the other third parties want something else. So good point, John.
Yep. What we do see, at least on that front, is on this and with the CPC Plus program that we were talking about a few weeks ago, and a bunch of programs I've seen at different state levels, is they are at least trying to get the various third parties together to try to agree on what it is that they want. So, instead of having 16 different requests coming to providers and, kind of one foot in each boat when you're dealing with the same patient panel, there's been some consolidation efforts there, which I think is a positive. And to your earlier point, lets us all look at one thing and evaluate one thing and try to improve one thing.
Well, there's a dark side to that too, though, Don, and there's some language in MACRA that sort of says that, we want to partner up with the other ones and have everybody speak with one voice. That's also an effort by CMS to expand its power base and begin to dictate to private industry what the standard should be, so that, what applies to Medicare applies to everyone. So, that may sound a little conspiracy theorist, but the potential is certainly there.
Sure. So I want to go back to a point that, Randall, you made earlier about not tying, it's okay to try to measure these things and try to learn from them, but don't tie compensation to them. Do you think that there should be any...
Only if you want to destroy the altruism and the morale of the health professionals, then go ahead and do it.
So alternatively, if we don't want to do that, what is the model? Is fee for service as it's been the best model if you start thinking about things from that standpoint?
I don't think so.
What would you propose in terms of how do we pay for healthcare? How do we pay physicians? How does the money move in your mind in the best case scenario?
Well, I think if we go back to the model of a few generations ago, where the third party system, the health insurance, it becomes insurance again. Health plans are for the catastrophic. The major events, the car wrecks, the cancer, those types of things. But if you had car insurance to cover for your oil changes and your gasoline, just think of the nightmare and the complexity. I mean, basic initial primary care, it should very likely be a capitated system like what we see in direct primary care, where CMS or the patient pays, $50 to $100 a month or whatever for individual, for that individual to have a home in the health system that can focus on what is the value to that patient. Because some patients, they value a Porsche where other patients are going to value a Kia. And no third-party system is going to be able to set across a population of unique individuals what's really of true value. But if the patient has an allocated amount and then a trusted professional that can help them navigate the system to get what's appropriate, to have the most prudent purchases within the healthcare system. To me, that looks like the only practical way that we're likely to navigate through this quagmire. And as this rewards based on outcomes fails, I predict this is likely what's going to emerge from the ashes, because if you look at like Q Alliance in Washington and a whole lot of medium-sized employers that are cutting their healthcare costs by sometimes 20 to 60% and are having higher patient satisfactions and by all measures better outcome, they're seeking direct relationships with the better practices in the community, are bringing clinics on site in order to help their patients navigate the system. So that would be what I suspect is going to be the likely outcome.
Gotcha. I'm with you in a lot of ways.
At the risk of sounding like a broken record, Dr. Oates, once again, no one could have said it better. That's, elimination, well, not necessarily elimination, but minimization of the role of the third-party payer, is clearly the way to go, because then everybody gets to make their own decisions for themselves, and you don't have this one-size-fits-all government approach to things. There's been a very clever sort of intellectual and verbal sleight of hand going on here. We've got this entire movement, everything from maintenance of certification all the way down to these quality measures, where the folks that support this stuff have kind of slid under the blanket, so to speak, this notion that doctors need to do their job better, independent of cost, that somehow we're incapable, after 4 years of medical school and everything from 4 or 5 to 10 years of residency training afterward, that somehow we need the supervision of bureaucrats. And that's not true. The problem is the cost is the problem, not the quality. That's the problem. And, through verbal sleight of hand, now we talk about it in terms of quality. We've got all these other things, nipping at our ability to do our job. And, we need to make clear what the problem is. And the problem is not that doctors are incompetent. The problem is not that, we need to be recertified by our specialty boards every few years, or that we need quality measures to be sure that we don't forget how to do our job between Friday and Monday. The need is to be able to do this for lower cost. And if you look what's happened with LASIK surgery, with plastic surgery, the trend is clear. Put patients in charge of their own healthcare dollars, and you will get rid of, the few black sheep that we have in our midst that are overutilizers, because that's really the problem. Right? The problem is really a matter of cost per unique patient. And we used to have a capitated network where we looked at that parameter, cost per unique patient. And it was great at identifying who the overutilizers were that were driving up costs. There are ways to do this and do it well.
Got it. Yeah, I dropped a link off on the side here for the book Catastrophic Care. I think that's come up here before too. Listen to Randall's description there. That's more or less the model that is described in that book. And I felt like, it is admittedly a bit of a long book, but I felt that the treatment of some pretty complicated like economic theory and background was really well done and accessible to a non-economics person like me. So I highly recommend checking that out. If you want to dig deeper into these types of topics. So with that, we got a little bit of time left here. I'd like to come back and talk about. So on the other end of this, like we said, there's going to be some quality measures. Hopefully, you'll get your feedback out. You'll get some positive changes in the rule. But on the other side of this, we'll definitely have, MACRA's coming through. These things are going to at least be tried out for the next couple of years. And then we'll probably see some other iteration. So I want to come back to some of the things that I pulled out in the post for this that I saw as opportunities. Get your thoughts and opinions on those. The one that I'd say two of them that I was really interested in. First is that they've identified telehealth and telemonitoring as being on par with in-person visits in terms of, at least of how they're looking at it and some of the advanced payment models. I'd like to just get reaction from you guys on that one. Do you think that creates good opportunities for starting to utilize these tools? And if so, how?
Well, putting telehealth in those quality improvement, I forget what the term is for that last table that's in the law. But there's a lot of things in there, maintenance and certifications in there. There's a lot of other things in there. And if memory serves off a 900-page document, I don't know that any of those are actually required or are a part of your score, the thing they use to ratchet up or down your Medicare reimbursement. But putting it there is fine. They did that to make somebody happy. It's not really going to move the ball with telehealth. I think telehealth's a great idea. But I think, someone needs to, and those regulations that really move the ball on telehealth probably have to occur at a state level as opposed to a federal level. But it definitely needs to happen. And I mean, the concepts are there. I'm not sure how much good it's going to do that it's in the regulation in a table at the end of 900 pages. I don't know.
Got it. You agree, Dr. Oates?
Oh, I think anything that encourages or promotes the ability of a patient's trusted health professional to communicate with them is a great thing. I mean, everybody's making this big deal about telehealth. Heck, for 30 years, I was doing telehealth. I just wasn't getting paid for it. Patients probably prefer the phone or texting to a fancy video interaction. And if we wanted to truly promote telehealth in this nation, we would require the health plans pay health professionals to deliver them now. And the adoption would explode. And in my practice, probably 60% of the patients I could have adequately managed via one of those telemedia methodologies and not require them to come in. But the health plans won't pay for it. This big push that you're seeing in telehealth is due to the lobbying by venture capital companies with these telemedicine companies that are promoting services to patients from clinicians that don't know the patient, don't know their unique needs and preferences. And I question whether that's going to ultimately be best. In contrast, if they just pay for the known trusted health professionals of that patients to deliver them. And to some extent, I see the MACRA rules are encouraging that, and I think that's a great thing. And the more of that, the better. But the more that you have a dial-a-doc to come in and prescribe antibiotics or other things that aren't probably the best approach, I don't see that as a good thing.
Got it. Okay, great. Next item that I was looking at was on the small practice side, fewer, that's up to 10 providers. having the ability to basically work together on the reporting or report as a group. From your perspective, does that create an opportunity for some groups to collaborate, at least at the service level, to the advantage of the small practice, or is that something that's not going to carry much impact?
I'd say it's worthless.
Okay.
There's no. I mean, it means if you're already in a group together, yeah, you can report together, but it really doesn't save a lot of work. You're still got to get the reporting right for every single individual doc. And if you're not in the same group and you're trying to collaborate, your information systems are so disparate that's not going to work either. That to me is just one of those things they threw in there so they could say, hey, see, look, we're supporting small practices. But in reality, I think it's nothing. I'm going to have to drop out, guys, because I got
okay.
So thanks again, and I appreciate you guys having me on.
Yeah, thanks for having on. It was great. Great to see you.
It's kind of like, I don't know if you did projects in school where you had a team and you had to work together on a project. And, typically you have one or two on the team doing most of the work and may or may not get the credit for the group. I think the jury is still out on that. It introduces a level of complexity and being held responsible for things over which you have no control, which I'm concerned that may be more of a problem than a solution. We'll just see.
Got it. And just for the last, we got about 15 minutes left here. If anybody else did want to jump on and had an opinion on something that you want to share, please feel free. You're more than welcome. And I'll just kind of continue with my last couple of questions with you. Otherwise, Dr. Oates, you good up to 1:30?
Sure.
All right, great. So the next one I'm looking at here is the sliding scale assessment versus the all or nothing assessment of the prior programs. And to me, I feel like that creates some, at least some business like operational planning opportunities for the practice groups where, and this is outside looking in, obviously I don't run a practice group, but if I now have the option where I can get to, this point and I'm going to get some of that incentive, that might be good enough for me as long as I can focus my efforts elsewhere. So do you think that's something that, running a smaller practice or running any size practice really, that you'll be able to look at and take advantage of and say, I'm gonna apply my resources, assuming I'm not going to hit 100% of these things, I'm going to apply my resources so that I get the best chunk of them that I can across all?
Well, I think that is one of the very best, if not the best things that's different about MACRA than the previous meaningful use program, which I think the numbers were stage one, there were like a little over 50% that of the eligible professionals participated. And with stage two, it was somewhere between 10 and 20%. I think I've seen like 13. And a big part of the dropout of that was the all or nothing clause, because there were, within that, in various regions, there was at least one requirement that a practice couldn't meet. And so what was the use of doing any of it if making 99 on a 100-point test meant that you failed? And because of the lack of infrastructure for interoperability, for example, or public health reporting or whatever, the practice couldn't meet it. That's why you saw a tremendous drop-off. So I think with the letting go of the all or nothing, we'll see more participation and hopefully more success.
Got it. Very good. Next up, there is two separate chunks of funding, and again, they seem to be focusing more on the smaller practices here. The first one is they set aside $100 million for technical assistance to smaller practices to help them get up to speed and comply with the rule. Has there been similar funding like that? Is that kind of like the rec funding that we saw through MU, or is that something else?
I have to say I'm not well informed enough to really comment, but $100 million is a drop in the bucket. If you really want to put in infrastructure and systems, I think they sent, between a half and $1 billion on the REC initiatives.
Okay.
And so I question the utility of that, but at least it's something.
Got it. Yeah, no, it's good to have that comparison to the rec number, because I didn't have that before, and I agree that makes it seem a little less significant. And then I'm looking at, this one's less of a funding issue in my mind. $75 million in funding for groups to work on defining requirements, but really when you read into what they're talking about here, is they're saying that providers will be able to get together and come up with evidence-based metrics that CMS would consider adopting for the program, independent of like any kind of like NQF or any of those groups. So do you think that if you can get a bunch of providers together and develop your own metrics, do you think that there are some evidence-based metrics that you could come up with that would be indicative of value and would be worth tracking?
If the evidence falls back to what's of value to the patient, and they can accept that, and we can develop measures at the point of care that don't require extra box clicking, that can just be derived from the recording the interaction with the patient, the degree to which they allow those two things to come into play, I think we could see more success.
Got it. And then the last thing from my list, I guess this would just be more of another what's your opinion thing, is I was listening to a podcast from the Premier Group, or I think it's just Premier, that they advise a lot of ACO type groups and practices. And the gentleman on there made some good points about what you should be doing right now. And this was kind of pre-rule, but post-law, obviously, coming out. And the commentary was, this presents a great opportunity for folks, healthcare organizations, to define what they want to be in the new market, because the new rules are forcing new ways of collaboration. They're going to, force the hospitals to look at who are the best partners out in the community. They're going to force the physicians to look at who are the best hospitals to be working with. And if you are able to take the time, understand the rule, and decide for yourself, what do I want to be in this new market, so that you can start broadcasting that, if you will, out to the community and kind of claim your spot, if you will, that it's a really good opportunity for people, forward-looking people, to go out and do that. Do you agree that there's an opportunity for, for anybody, for a small practice, for larger groups, for the hospitals themselves, to do that type of thing right now?
I'm not convinced yet. I think we have a proposed rule. We're in the comment period. It'll be this fall before we know the final rule, and to be spending a great deal of effort trying to anticipate what's going to be a final rule, I think there's enough risk in that. I mean, personally, and I come from the perspective of mostly dealing with smaller practice, so my perspective may be a bit biased, since 87% of solo practitioners expect to be negatively impacted, and 70% of practices of 2 to 9 physicians expect to be negatively impacted, even though they're the ones that are shown in multiple studies to provide the highest value at the lowest cost. The extent to which the systems can shift to focusing on what is of value to the patients, I think that's good. I mean, most of the marketing dollars have been in, we have the best cath center, or heart center, or stroke treatment center. And the more to the degree that they can focus on, we're going to see you on time, we're going to get you appropriate care, we're actually going to notify your primary care doctors when you were admitted or discharged. It's a real I mean, patients assume that their primary care doctors know when they were in the emergency room or were discharged, but that's actually the exception. And if hospitals can make it a point to publicize how they're collaborating to coordinate care, that's a great thing. And that, to some degree, is the intent of MACRA. And I hope to see more of that.
Gotcha. So to paraphrase, you're saying identify what are the major themes that you know are going to stick: the care coordination, the interop, that under any changes to the rule, these things are going to be part of it. So maybe focus your efforts there now during the comment period while you're working on the comment period, and
absolutely
kind of regroup.
But I would say that regardless of MACRA.
Yeah,
and those are the things, you know, that really bring value, lower cost, and improve the quality.
Got it. John had an interesting question for you down here too, from your company standpoint. Do you see changes coming down from MACRA that are going to be like where, you know, all EMR vendors were trying to meet MU requirements? They couldn't do much else. Do you think that you're going to find yourself in that type of situation again here?
Yeah, I'm grieving to a great degree with the MACRA rules. We're going to have to shift our focus to meeting these requirements rather than doing the things that we've been able to do the last few months that our users really want and truly bring value, improve communication and care coordination and the interaction with the patient and their health professionals. We're having to put that on the back shelf and develop toward these requirements, which I question are really going to be bringing value or lowering the cost of care. I am grieving that we're going to have to shift that focus, and probably will for some time to come.
Okay. Is that the same type of thing though, where you're gonna hold off until final rule come September and then start to address it?
Well, we've already been doing a lot of the things that are in MACRA, so it's not going to be a huge shift. But it is we don't have the liberty to truly be creative and innovative and do it the best way. We have to focus our resources on doing it the way that the requirements demand. There's a big difference there.
Got it. Thanks for that, John. That was a great question. So with that, you know, obviously my goal was to start ferreting out all these great opportunities, and the feedback we got from you guys is that's like, hold on, you know, we're not quite there yet. But, you know, according to Dr. Oates here, there's some things, and I agree, that are inherently going to be part of it. And whether MACRA is there or not, starting to think about how you can better communicate, how you can better coordinate care, all things worth digging into now.
Yes.
And trying to do a better job for your patients on that front. And that should, you know, if that doesn't put you in a good situation when the law is finalized and the rules are finalized, then we're probably off track, I would say. So I'd say we're going to wrap up. We'll end a minute early instead of a few minutes late like normal. Given what we learned today and what I've learned over the last couple of days with MACRA, I think this is probably a topic that this group puts down for a little bit while from the HCBiz standpoint, and come back once that final rule is established in September, because that's when we'll be able to really start to talk about, okay, what are we going to do about all this stuff? And, you know, now what opportunities exist, and what new tools can we bring to market, and how can small practices band together and work together to meet some of these new requirements that they got to do. So that's likely going to be the plan. We've got a bunch of good shows planned coming up, and I'm going to try to start getting you guys topics a few weeks in advance instead of about 24 hours in advance as I have been. So look for that. Hopefully soon we'll start to gain some headway. I just want to say thank you again, Dr. Oates. You've been on a couple of times, and as Dr. Mike said, you're always very quotable. I appreciate your thoughts. I appreciate you spending some time with us, and thank you to everyone else for joining.
Thanks so much.
All right, we'll see you next
Have
week.
a good day.
You too.